Welcome. Come with me. The doctors will see you now.
Welcome again to Fast Talks with Family Docs. I'm Dr. Phil Palmer.
And I'm Dr. Veer Vadala. Today we're joined by Dr. Robert Salinas, the Nancy K. Hall Endowed Professor in Medical Education and Assistant Dean for Access and Community Engagement at the University of Oklahoma College of Medicine. Dr. Salinas is a triple board certified physician in family medicine, geriatric medicine, and hospice and palliative care. He serves as the Director of Community Medicine and is the founding medical director of the OU Medicine Palliative Care Program. A champion of community health, Dr. Salinas has advised the CDC and contributed to the 2022 National Opioid Prescribing Guidelines. His work has earned him numerous awards, including the Easter Seals District Inspiration Award, the Leonard Tao Humanism Award, and induction into the Gold Humanism Honor Society. Today, we'll explore the world of geriatrics, team-based care, and how we can build a stronger, more compassionate healthcare workforce. We are so thrilled to have him. Thank you, Dr. Salinas, for being here.
Yes, definitely.
Great. Thank you both for the invitation to participate today.
So let me start off just talking about the field of geriatrics. Yes. So our population is aging, and healthcare has allowed people to live longer than they ever did before. So give us and our viewers an idea as to, first of all, how you got into the field of geriatrics, and then secondly, for family docs who maybe haven't ever considered specializing in geriatrics and doing a fellowship and can't do a fellowship, what they need to have in mind dealing with an ever-aging population.
Wonderful. Those are great questions. So, you know, in full transparency, I'll tell you my story in terms of how I entered the field of geriatrics or developed an interest in caring for our older population, members of our community. I was a medical student at the time, doing a rotation with the well-known pulmonologists, and during the daytime we were in clinic and doing procedures and doing lung biopsies and what have you, and pulmonary function tests. Yeah. And then in the evenings he would go out to see some of his very frail patients. And one night he asked if I would go along, if I wanted to take along. I said, sure. Yeah. So we went out and we went into these neighborhoods to go see these homebound elderly people who were afflicted with a number of different illnesses, heart failure and right. advanced asthma and COPD. And I started to look at this differently, and I thought, hey, I kind of really like this, the idea of being welcomed into someone's home and caring for them at their level, at their home. So when I became a resident, I started to think a little bit about, in family medicine, can I really take a look at this? But then I realized that I didn't feel very comfortable as a resident. In fact, in full disclosure, there was a time when I was afraid of caring for the older patient. And a lot of my current residents, I tell them the story that when I was on call, the emergency room would call and ask, are you on call for Jim Mold, one of our well-known faculty members, and Peter Wynn? And I said yes, and I would worry all the way to the emergency room because I was really fearful of not knowing enough about the older person. But my mentors, Jim Mold and Peter Wynn, saw something in me, and they encouraged me to take a closer look and more introspective in terms of how I felt. Yeah. And sure enough, I ended up doing a fellowship in geriatric medicine and have enjoyed it. I see patients in clinic, in the hospital setting, and I do home care as well.
Okay. So tag on back to that. What should family docs consider, residents considering family medicine, about the care of an aging population? What nuances are there in an elder population, especially extreme elders, 80 and above, that we need to be attending to?
Mm-hmm. That's a very good question. So when I went into fellowship, I was told that we would need about 30,000 geriatricians by the year 2030 or so, maybe 35,000. And I just took a look today, and there's maybe just about 7,000 of us that are board certified. So we don't have enough geriatricians. I don't think we'll ever close the gap.
All right.
The majority of fellowship programs are internal medicine or family medicine. It used to be a 3-year fellowship, went down to 2, and now it's 1. So I don't know if we'll ever really get there. So we really have to educate our family medicine residents and our practicing physicians on how to approach the care for the elder person as well. Mm-hmm. So we often start with understanding that as we get older, our needs do change. there's physiological needs, for example, that do occur. So you have to be a little bit aware of that. But when we take care of the older person, I go back to what we often talk about is patient-centered care. By asking questions about, what matters most to you, what's important for you, and how can I help make a difference in your life in terms of what are your goals. And that goes back again to our mentor, Jim Mould, who's written a few books on the idea of goal-directed care. So a lot of it is about listening to the person that sits in front of you. And you're right, we have an aging population. Each year, each day, there's about a good number of 10, maybe 11,000 Americans that turn 65. Our boomers have now aged, so we have to be aware and more cognizant of that. But in my practice, what I often do is get to know the person in terms of what's important for them, what matters to them. And I focus on three aspects of their care. And one of them is making sure that they're as active as possible. Functional status is extremely important in this population, asking about their activities of daily living, instrumental, who's at home, what's a day like for them. I then ask them about their mentation in terms of are they staying active, actively engaged and doing things at home. And then I ask about their social connections. And social connections are extremely important as we get older. We learned from COVID, for example, that isolation was very detrimental to our elders. So those are the three things that I bring out at every visit to remind my patients. At the national level, actually, someone has decided that there are 4 M's that we should ask at every visit, which is asking about what matters most to you, asking about the mind, mobility, and medications. And I was having this conversation with my wife the other day, and I said, I need another M for social connections. And she came up, and I'm going to credit her. She came up with the term mingling.
That's great.
Yeah, she says you gotta get out. You gotta mingle. You gotta get out and interact with others. But we think if you could do that, that allows you to engage more and stay as active as you can.
Yeah, and that's oftentimes one of the big obstacles is as individuals have progressive health issues, they may not be able to drive any longer, or they may just be fearful of getting out and driving, and then that creates that social isolation that can be such a problem.
It does. In fact, I think in the U.S., if we take a look, there's maybe 45 million or maybe 50 million caregivers who are providing care for a loved one at home. But you're absolutely right. So the other thing that we bring in is to turn to the caregiver and ask, how are you doing? How are things going for you? Many times it's a family member who has given up their job to take care of mom or dad at home to do the best they can. So checking in with the caregivers is one of the other things, and I'll have to figure out another M for that one.
That's right.
Yeah, that's good. You should patent that mingling and publish that, sir.
My wife gets credit for that. She's the one that came up with it.
She's lead author.
She's lead author.
Speaking of driving, sir, as Dr. Palmer so eloquently put it, it's not just social connections. Sometimes they have problems even coming into the clinic to see their provider. And, during COVID, we were able to utilize telehealth, and it was such a valuable resource. And, now there's some concerns that telehealth might not be a valid opportunity that we could use moving into the future. Do you, have you seen, telemedicine and maybe, remote monitoring evolve in our geriatric population, at least in their care over the last few years?
Yes. In fact, there's something magical that happens when you can sit in front of a person. And we know that now. We were talking earlier about the electronic medical record and how we journal. But I really believe that the future will involve telemedicine and remote patient monitoring that will allow us to provide better care for our patients. In fact, we have been doing remote patient monitoring with home med devices for heart failure for, over 20 years. One of our former faculty, Dr. Phil Adamson, well-known cardiologist, and I remember working with the home healthcare agency that introduced that. I believe that telemedicine and remote patient monitoring will continue to evolve as NASA is now sharing a lot of information with us. And I really believe what's going to happen are two things. One, the reimbursement will come back and will stay there. The equipment's going to be there. The only thing that I worry about in remote patient monitoring is the boundary or the ethical question of, let's say Phil's having dinner with his family and Phil decides to have a glass of wine. Does he want his phone saying, check on Bob because his weight is up 2 pounds? And you're at home with your family at 8 o'clock at night, but your remote patient monitoring alarm triggers and says, Bob's your patient with heart failure, EF of 20%, and his weight is up 3 pounds. Do something.
Yeah.
So we have to be careful with the boundaries and the ethics of it. I think the reimbursement will be there. Certainly the equipment is there now. In fact, I don't know if I'm allowed to say this, but there's a well-known business in the community that sells electronics that is now heavily involved with telemedicine and remote patient monitoring.
Oh. Okay.
And I'll just say that's happening as we speak. So I really think it's gonna make it for those patients who are isolated, who live in rural communities, who find it very difficult to get into clinic.
Yeah.
That'll be a great resource. So you do home visits.
Yes.
I think one of the things separate from driving is just mobility around the home.
Yeah,
that's so important. And physical activity can be hard to do if you can't drive to the gym or drive to a park or if your neighborhood's not safe to walk in. So I've seen and read about, chair-based kind of body weight activities, and there's a lot about Tai Chi in the elderly. I'm just curious what you found valuable in interacting with your patients in that regard to help them stay physically active in the home.
One of the things that I do when I meet with my patients and their family, I watch them walk into my clinic to see how they're walking in. Are they using a durable medical equipment, a cane, a walker, to try to figure out, how they're functioning. And when I can, I'll make a home visit and or utilize the home health care benefit and work with the physical therapist at home. Sometimes when I make a home visit, I'm able to do an environmental assessment. If the therapist can do that for me, that's even better. And then you start to put it together. You start to see some of this furniture walking that occurs at home or nesting. It's another example where it tells you that someone is not moving around a lot. But we often put in strategies to try to mitigate falls, and that's what you're really talking about. Falls in the elderly is a huge problem. Yeah. In fact, I've done some work with the CDC and to help embed their STEADY program into our EMR. And more recently, they reached out again through the Oklahoma Health Department. Oklahoma and Iowa are 2 states right now where falls in the elderly have reached high numbers. So we have to be very careful and do the best we can to keep our patients as independent as possible. One other thing that I do besides checking their vision, hearing, their sensory systems, I take a look at the shoes. And we're talking about geriatric care and things to do. But I have told my wife if I wasn't in the field that I'm in, I would probably sell shoes because I think that many times I see people that are not fitted well. Okay. And as a result, I believe they contribute a lot to falls. They may buy shoes that are not properly fitted, and as a result, they may fall and have an accident. So those are the kind of things that I do is to try to keep people as functional. And then we call that the F word in geriatrics. I don't know if I'm allowed to say that, but we really
we'll edit it.
We'll edit that, but
we'll bleep it.
But we really try to keep people as functional as possible, and that's the mobility factor. I had a talk this morning about what are called the blue zones in the world, and there's 5 of them where people live up to 100 and above. In Sardinia, for example, the island of Sardinia. But walking and mobility is one of the things that they do. Yeah. So important.
Yeah. I think that's it's been a focus and, I think up and coming medicine now, whether it be sports medicine or making the non-functional functional. We had a talk with Dr. Barrett and Dr. Owens talking about that and being able to do what we do now when we're 80 years old. I think that should be the goal and everybody's dream. Yeah. That's fantastic, sir.
I want to pick your brain on something you said. So can you explain briefly the physiology, if you're aware of it, behind hearing loss and increased falls? Visual loss seems to make sense.
Yeah.
I can't see the obstacle. I will trip over it. What is it about hearing loss that increases fall risk?
Well, it's multifactorial. You know, of course, besides having some sort of episode where you can have vertigo, for example, benign positional vertigo. You may not be familiar with your surroundings, for example. You may run into people if your vision and hearing is not very good as well. But I think what happens is the isolation. And now you don't want to be around other people because you can't participate in the conversation, and you start to isolate. Having said that, I've found some patients that actually enjoy that because they don't have to listen to their family argue and go back and forth. But I think that's one of the things that we worry about is that a lot of times, in fact, there's a wonderful paper called The Disablement Process where you can actually look at one particular pathology that leads to something else, and eventually it's going to be a fall and broken hip, pneumonia, and death. But part of it is keeping people as active as we can. But we think if we can keep them functional and their senses working well, they may be able to participate and engage more.
Excellent. I know there have been times that, as I've talked to medical students when they've come through our location, that the concept of elder care, geriatrics, and end-of-life care is something they really have no interest in. And to an extent, I think that may be because they get a skewed perspective. Most medical schools are at a tertiary medical center, so they're seeing the sickest of the sick, often at the very end of life, often unexpected illness that they've learned about shortly before they came into the hospital, and often very poor social supports. And fortunately, that's not the reality for the vast number of elders in our country, but that does, I think, skew a medical student's perspective that geriatrics and hospice care and palliative care aren't really something that I would enjoy. It's too sad to deal with that all the time. And there certainly is a degree of sadness for end-of-life care, but how would you reframe those aspects of medical care for medical students who may be listening to our podcast, and what value have you gotten out of being able to be involved with people through those stages of life?
Well, you know, I will share with you in doing this for 25 years now. Now I'm giving away my age, but that's fine.
I'm at 29. That's okay.
I've learned that in taking care of people and families, you know, it's an honor. It's always an honor to be part of their care plan, and to help them through this journey. Yes, I've been there when I was a resident, and we would bring people into this life, and there were high fives and crying, and people were just excited to see the newborn, and so forth. But we're also on the other end where we have to help folks who are experiencing a serious illness. And what I found is that people don't have a lot of time, and traditionally doctors have not had enough time. So I go back to a book called Slow Medicine by Victoria Sweet, who's at UC San Francisco, I believe, who talks about how we have to slow things down for those people that need more of our time. But throughout the years, I've found it to be very rewarding in terms of being able to help people through a very difficult time. And as a geriatrician, a good portion of my patients will die. And as a hospice and palliative care physician, sometimes I'm called into a consult where I just meet a person for the very first time who is having a very difficult time with an advanced cancer, end-stage liver disease, or another serious illness that is going to make it very difficult for them to leave the hospital, for example. But what I find remarkable is that we can still make a difference in the lives of these people. And what I find very ironic is sometimes there's this feeling of grace or on their part that, hey, someone was able to talk with us and help us during this most difficult time. And when I walk away and they're thanking you, it's kind of incongruent. You just met with the family to give them some of the worst news, and yet they're grateful that you were able to do that. So so maybe you're asking about how do we reframe it and change the culture. I think one way to do it is to get students exposed a little bit more to what we traditionally have called end of life care, but now palliative care is important because that will also help people do well and live the best they can with the serious illness. Right. So along the way, it's about kind of introducing students to different perspectives. Now, I will say that at one time there was a culture that death could be seen as failure, that we as physicians failed.
And I honestly think that still exists in a lot of people's minds today.
Right.
Yeah.
Oh, so now you tell me more. That's a palliative care technique, by the way, and asking people to tell you more. But no, so you're right. You're absolutely right. Sometimes it can come across as failure. I remember when I was an intern, we were rounding on a patient with the surgeon who we knew the results of the CAT scan. It wasn't good, but we went in to see the patient and the family. And, of course, they were worried, and he kept saying, don't worry, it's going to work out. Don't worry, you'll be fine. And when we walked out of the room, I kind of looked at him and gave him that look of askance. I said, wait, it's not good. Why didn't we say that? And, well, we don't want to take their hope away. And I thought, so along the way, we learned to embrace hope. Yeah. And folks are resilient, and they may hope for other things if it's not a cure. But I remember that just when you were mentioning this, that there was this fear that maybe we failed.
Yeah, I think that so often we rob patients to a certain extent if we don't level with them and be honest about how severe things are. You started our interview earlier making the comment, and I agree wholeheartedly with you, that we need to, with all of our patients, but especially our elder patients, we need to be asking them, what matters most to you, and what are your goals in life and your goals for your health care? And if we've not given them a realistic understanding of their current medical condition, then they don't have the opportunity to really weigh the weight of those questions and come up with an appropriate answer for themselves.
Mm-hmm. And you're right in a sense that will take us to when we talk about clinical ethics. Autonomy and being able to weigh their options, but you're essentially asking them, in terms of information sharing, to make sure that you understand them and they understand you as well.
Yeah. Fascinating conversation. We're going to put a pin in it right here and take a break. Viewers and listeners, thank you for joining us, and we will see you next time on Fast Talks with Family Docs.
Thank you for joining us today. The doctors would like to see you back for another check-in. Please choose to follow our podcast, and you will automatically be notified when it's time for your next appointment.